right, guys, it's me, Professor D, and welcome back to my YouTube channel. Happy Nurses Week. We're going to be doing a Kahoot. I know you haven't seen me in a couple weeks. I've been really busy, guys. I have so many projects that are rolling out very soon that I'm very excited about introducing. But guess what? I made time today. We're going to be doing a Kahoot. We're going to be going over, what are we going over? Nursing exit. Yes, nursing exit topics. Um, Things you absolutely need to know and you need to know well before you take your nursing exit. If you're preparing for boards, this is great content that you need to know as well. So if I'm talking about it, make sure you study it, make sure you know about it. We're going to be going over that. If you haven't done so already, please check out my YouTube channel, Nexus Nursing. You can find me covering a variety of nursing topics almost daily. TikTok, Instagram, Facebook, YouTube. And you know what? I'm saying almost daily, but right now I'm lying because, like I said, it's been a couple weeks. I've been MIA, but I've been MIA because I've been preparing some good things for you that are rolling out. I've got my Nexus Nursing Test Bank that should be rolling out shortly. And I also have my next generation NCLEX cheat sheet. I wrote a book, I put it together for students all over the country. If you're taking NCLEX, I have a list of topics and I'm being specific about things you better know before you go take your exam. And it doesn't matter what state you're testing for. So that's rolling out very shortly. And so that's where all of my time and energy has been going into. So please be sure to check my website, nexusnursinginstitute.com, for any news on that. You guys can check my content, TikTok, Instagram, Facebook, YouTube, lots of great content on there for you as well. I feel like I'm missing something. I haven't been on here in so long. I feel like I'm missing something to tell you guys. Anyway, it'll come to me. It'll come to me. If I remember in the middle of Kahoot, I'll tell you what I was thinking that I can't think of now. Anyway, so that's what we're going to be going over. Please make sure you go grab a paper and pen to be taking notes because, like I said, all of these topics we're going to be going over are important topics for you to know. All right, guys, without any further ado, let's get started. Nursing exit concepts. First question. A patient presents with AFib and a rapid ventricular rate. Which medication would the nurse anticipate administering? Would it be atropine? Would it be amiodarone? Would it be diltiazem? Or would it be epinephrine? Again, your patient presents with AFib, or I spelled AFib wrong, but it's AFib. AFib and a rapid ventricular rate. Which medication would you anticipate administering? Atropine, amiodarone, diltiazem, or epinephrine? I'm recording. Thank you. Guys, here's the thing. Diltiazem, which is a calcium channel blocker, that specifically, guys, is going to control that ventricular rate in AFib. Patient has AFib and a rapid ventricular rate. Now, if this patient had VTAC, they had VFib, we'd go with amiodarone. Okay? The thing is, let's go through the different options. The first one, atropine, that we're going to use to increase the patient's heart rate if they had bradycardia. So if your heart rate was less than 60. The next option, amiodarone, again, VFib, VTAC. The thing is, amiodarone, yes, it's a great antidysrhythmic agent, but specifically, guys, we're talking about the patient has AFib and a rapid ventricular rate. That's the difference. Because it's an AFib with a rapid ventricular rate, we're going to go with the diltiazem, which again is a calcium channel blocker. If it was a VTAC or VFib, absolutely, we go with the amiodarone. Last, epinephrine. Epinephrine, guys, we're going to give for like if the patient has like, if the patient coded, patient had VFib, patient had pulseless electrical activity, then we would have gone with epinephrine. You guys with me? Arham, you don't have to be on this live. If you don't like all my yapping, all you got to do is exit. Nobody's forcing you to be here, honey. Goodbye. This is a free country, guys. This is America. Nobody's forcing you to be here. Okay, which ECG finding is most indicative of VTAC? Would it be irregular rhythm with absent P waves? Would it be sawtooth flutter waves? Would it be wide QRS complexes over 100 beats per minute? Or would it be normal QRS with inverted T waves? Again, patient ECG findings, you're seeing VTAC. What would you be looking at? You guys are all over the place on the live. Okay, very good. Wide QRS complex and heart rate over 100. Perfect. That's the correct answer. Now let's look at the wrong answer choices. Irregular rhythm with absent P wave. When you see that absent P wave, guys, I want you to think of the AFib. Next, it says sawtooth flutter waves. What would we be looking at? A flutter, right? And then last, normal QRS with inverted T waves. When you see inverted T waves, that tells you that the heart muscle itself is not getting enough oxygen. Maybe patient's having an MI, but it just means that heart muscle itself is not getting enough oxygen, but it's not specific to VTAC. Which finding best indicates decreased cardiac output in heart failure? Would it be bounding pulse? Would it be warm extremities? Would it be a capillary refill less than 2 seconds? Or would it be confusion and decreased urine output? Very good. Confusion and decreased urine output. So the question is asking about decreased cardiac output in heart failure. Heart's not pumping out enough blood to oxygenate the tissues like it's supposed to, right? So, what do you expect to see? Of course, confusion. Why? The brain's not getting enough oxygen. Remember, oxygen is carried in hemoglobin, which is carried in RBC, which is part of the blood. That blood is not getting to the brain like it's supposed to. So, yes, you're going to see a change in the patient's cognition. Also, urine output. Why? The body's trying to protect itself. So urine output, which is supposed to be at least 30 mLs per hour, you're gonna see that go down. And then what is going to happen, because the body's going to try to protect itself, that oxygenated blood is going to be redirected to go to the most vital organs, such as your brain, your kidneys, your spleen. Which lab value requires immediate attention in a client taking furosemide? Would it be a sodium of 135, a potassium of 2.9, a glucose of 110, or a calcium of 9.5? Which lab value requires immediate attention in a client on furosemide? Very good. Potassium of 2.9. Furosemide is a potassium losing diabetic, potassium losing diuretic, right? And so we know if that potassium is less than 3.5 or higher than 5, it can cause a patient to have cardiac dysrhythmia. So we're going to be very concerned if their potassium level is so low. Another thing you need to know, if a patient is taking a potassium losing diuretic such as furosemide, you have to know what kind of foods you're going to encourage that patient to eat. You're going to teach them to eat foods high in potassium. Watermelon, potato, bananas, apricot, avocados, figs. You need to know those foods high in potassium. Now, on the alternate end, if the patient's taking a medication such as spironolactone, that's a potassium sparing diuretic. Whoa, they're holding on to their potassium. So we don't want them eating any of those foods that I just mentioned. So those foods that are high in potassium, you're going to have to know them regardless, either when to teach the patient to eat them or to stay away from them. All right, which symptom is most consistent with peripheral arterial disease? Brown discoloration of the legs, pain relieved by elevation, dependent rubor and hair loss, or warm edematous legs? Which symptom is most consistent with peripheral arterial disease? Wow, 17 of you guys went brown. Okay, so let's talk about this. The correct answer, guys, is dependent rubor and hair loss. So when that leg is in that dependent position, you'll see that rubor. So let's talk about it. You have peripheral arterial disease that includes, both your arteries and your veins, and then you have peripheral vascular disease, that's just your veins, right? Now, the way you remember that, PAD versus PVD. PAD, look at my hands. That kind of makes an A, right? Kind of looks like an A. So the problem in PAD, pathology wise, is blood going down to the extremities. So the blood's up here towards the heart. The problem is it going down to the extremities. And that's why that patient will have intermittent claudication. They start walking around and they'll have pain in their leg or their foot because as you move, your body demands more oxygen. Well, again, if I have PAD and the problem is that oxygen, that blood going down to the extremities, as I have a higher demand for oxygen and I don't get it, I'm going to have that pain, right? Then you have PVD, V. Look at my two hands, guys. Doesn't that make a V? Yeah, it does. So the problem here is that blood and oxygen going up back to the heart, right? So all of that blood and oxygen is down here, and the problem is going up to the heart. That is an easy way to kind of remember those symptoms between your PAD and your PVD. Anyway, let me go over the wrong answers. So we're talking about PAD. Not the brownish discoloration of the legs. The problem is getting that, again, blood flow down there. Pain relief by elevation. Actually, no, elevation is going to make it even worse because we're already having a hard time getting the blood and oxygen down there. And no, they're not going to have warm edematous legs. The problem is getting the oxygen and the blood down there. We see that in what? PVD. Okay, guys, make sure you know the difference between your PAD and your PVD because it can get tricky if you don't understand the patho behind it. Okay, which intervention is most appropriate for venous insufficiency? Walking frequently, keeping the legs in the dependent position, applying compression stockings before getting out of bed, or massaging the legs. What do you guys think? You guys are killing me on this live. Okay, I was seeing lots of reds and lots of yellow. So let's talk about it. Yellow's a correct answer. Applying compression stockings before getting out of bed. We're talking about venous insufficiency. We're talking about the V. So the problem is all the blood is all the way down here in the legs. The problem is getting it back up to the heart. Apply compression stockings. That's going to help push the blood back up. Now, on the live, a lot of you guys said red, walking frequently. Yes, walking does help to push all of that blood, the oxygen, blood, not oxygenate, but all the blood back up to the heart to go pick up oxygen. Absolutely. But can you be walking 24/7? Absolutely not. Walking is very good. If the compression stockings were not here, your answer would have been walking frequently. But when you have to choose between walking frequently, and frequently isn't really an objective term. What's frequent to me may not be frequent to you. That's not really objective. Versus applying the compression stockings. Before you get out of bed, you're going to have those stockings on, and you only take them off when you're going to take a shower, you're going to take a bath, or you're going to sleep, right? So when you have it on that whole time, it's going to help to push that blood back up to the heart. And that's why compression stockings is the correct answer and not walking frequently. Okay, a 3-week-old has projectile vomiting and visible peristalsis. What condition would you suspect? Would you suspect Hirschsprung's disease, intussusception, pyloric stenosis, or gastroenteritis? You guys think? A 3-week-old that has projectile vomiting and there's visible peristalsis. Very good. Pyloric stenosis. Now, another way that it can be described on your test is olive-shaped mass. And that olive-shaped mass, excuse me, you see that, I want you to also think of pyloric stenosis. That projectile vomiting, I'm telling you, that baby's throwing up, and that vomit is going clear across the room because of all that pressure that has built up. Okay, now let's talk about the other options. Very good. That's right. Let's talk about the other options. Hirschsprung's disease. In Hirschsprung's disease, the patient is missing, what is the name of that nerve? It's A something. A means without. Agangliotic cells, okay? The agangliotic cells are missing in Hirschsprung's. You need to know that. And so what's happening is the rectum that's supposed to, enlarge, get bigger, right? It doesn't. So when the patient has to have a bowel movement, you have all of this fecal matter that's supposed to go through this tiny, 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 tiny little, rectum because it's not expanding. And so in Hirschsprung's disease, you're going to see the ribbon-like stools. It's going to be nice and skinny because they don't have the ganglionic cells, and so that rectum is not dilating or expanding the way it's supposed to. Next option, intussusception. Intussusception, what's happening? Their GI tract is basically telescoping into itself. And so as it's telescoping into itself, all of, those blood vessels and nerves are also being pulled and stretched. And so when the patient has a bowel movement, you'll see blood, mucus mixed in with the stool. And so it'll look jelly or current-like. That's going to be the description that you'll see on the exam, most likely. Last, gastroenteritis. You suspect gastroenteritis, the patient got it coming out of both sides. They got vomiting and diarrhea. That's what the gastroenteritis is going to look like. Which finding in intussusception requires immediate attention? Would it be abdominal pain, red jelly stools, vomiting, or normal brown stool? Which finding, if your patient has intussusception, which finding would require immediate attention? Oh, you guys are a hot mess. I'm about to have a field day with you guys on this live. Are you kidding me? Okay. Okay. Mm-hmm. That's a damn shame. 42% 2 of you went with red jelly stools. Let me get this right. The question said, which finding in Intussusception requires immediate attention? I just told you that in Intussusception, a clinical finding that you will see in Intussusception is red jelly stools. The question didn't ask you what is a clinical manifestation of Intussusception. It asks you what requires immediate attention. When you see this, you have to do something right away. And you guys went with the clinical description of what you're going to see when the patient has Intussusception. Why? I'm going to tell you why. I'm so happy you asked. Hold on a second. Oh, you're lucky. You know what? Okay, I'm going to explain to you why. I'm going to tell you what the answer is first, then I'm going to explain to you why. The correct answer, guys, is normal brown stool. Yeah. That's the one that requires immediate attention. Why? When the patient has Intussusception, like I said, the patient's GI tract has basically telescoped within itself. And sometimes it will spontaneously resolve itself. Sometimes it won't. We may have to use gas, patient may have to have surgery, but sometimes it does spontaneously resolve itself. How can you tell if it spontaneously resolved itself? All of a sudden, that stool that was red, jelly, current-like because of the Intussusception is now normal and brown. Why does this require immediate attention? You as a nurse, you got to pick up that phone and call the healthcare provider right away and say to the healthcare provider, we got normal brown stool. Why is that important? Surgery's canceled. Or we were going to go ahead and do another procedure with that patient. We can cancel it. This is a famous nursing test question, guys. Make sure you know it. Guys, on the live, please, that troll, just ignore them because at the end of the day, you're trying to get your license. Just ignore them. All right? Okay. So this is what you're going to do. Brown, normal brown stool. The minute you see that stool's normal brown, you're running to the phone to call the healthcare provider and let them know. Normally, when a question asks you which one requires immediate attention, 98% of the time, guys, your answer is going to have something to do with that patient's life being at risk or their safety being at risk. Very few times is it something good that requires immediate attention. This is one of the very few times. This is something good, but it's going to require immediate attention. What diet is most appropriate during acute diverticulitis? Is it a high fiber diet? Is it a low residue diet? Is it a high protein diet? Or is it a stimulant laxative? What diet is most appropriate during acute diverticulitis? And while you're thinking of your answer, anyone on this live, if you're like me, if you have a speech impediment, or maybe English is not your first language and you pronounce words differently, that's okay. As long as you can recognize that word, you can spell that word, you know what it is, you're good. Okay? The important part is that you know this information. Very good, guys. Low residue diet. Why? Look at this. Acute. There's a difference between diverticulosis, osis, and itis. Itis, which is what we're talking about right now, that outpouching, that weakness is inflamed. So if the patient has diverticulosis, there's a portion of their GI tract that has become weak, and there's an outpouching, and so things like seeds or anything else can kind of get stuck there, and over time what happens? Bacteria starts to grow, it can become inflamed, and now you got diverticulitis, which is worse than otis, not otis, osis, right? So during acute phase of diverticulitis, where it's inflamed, you want the patient to have a low residue diet. You don't want their GI tract working overtime. And that's why we didn't choose a high fiber diet. We're trying to rest the gut. Okay? What colostomy finding requires immediate action? Would it be a pink moist stoma? Would it be skin irritation? Would it be mucus discharge? Or would it be dusky Dusky colored stoma. Which colostomy finding would require immediate attention? The code to get in is 347-1011, 347-1011. Very good. Dusky colored stoma. Now tell me on the live, guys, why? Why is a dusky colored stoma such a problem? What are we concerned about? What does it mean? That's right, decreased blood flow. Perfect. Okay, which symptoms should be reported immediately in a child on corticosteroids for nephrotic syndrome? Is it puffy eyes, fever of 101.2, increased appetite, or mild hypertension? Your patient's got nephrotic syndrome. They're on corticosteroids. What requires immediate attention? Very good. Fever of 101.2. Even if you didn't know what the answer was as a student, you should say to yourself, okay, what's the worst case scenario here? And it would be fever of 101.2, even if you guys didn't know what the answer is. Now, let's talk about it. I want to show you something that test writers and NCLEX does a lot to trick you, and I don't want you to fall for it. Look at this question. It says, which symptoms should be reported immediately in a child on corticosteroids for nephrotic syndrome? Lots of students make the mistake and answer the question based on this. Look at the mouse. Based on this, the disease. You guys see this? That's a big mistake. The patient already has the disease. Whenever there's a question and they give you the disease and a medication, either a medication that you're about to give or you just gave, your answer is going to be based on the medication. Patient's already got the disease, but you're about to put a chemical in that patient's body that is going to cause a change, or you just gave that patient a chemical that is about to cause a change. Don't fall for that trick, because as a student, if I'm looking at this question and I base my answer on nephrotic syndrome, I would have chose puffy eyes or maybe the hypertension, right? But no, the question's really asking about corticosteroids. I'm going to say this again. When you get a test question and they give you a drug and a diagnosis, base your answer off the drug. In this case, corticosteroids. Now, let's talk about nephrotic syndrome, then I'll get to the corticosteroids. So nephrotic syndrome, whenever you see that word syndrome, all it means is cluster of signs and symptoms that kind of point to a disorder. So that patient that has nephrotic syndrome, there are a couple things you absolutely need to know about this disorder. One, hyper proteinuria. Patient's going to have a whole lot of protein in their urine. Are you ever supposed to have protein in the urine? No, your kidney's supposed to be the gatekeeper. As soon as that big old, whatever it is, protein, when that protein gets to the kidney's supposed to say, oh no, you are not leaving the body. You're going to go back to the blood where you belong, right? But the kidney's in trouble. So instead of the protein going back to the bloodstream, it comes out in the urine. You're never supposed to see protein in urine. Patients got nephrotic syndrome, you're going to see lots of protein in the urine. That's number one. Number two, patient's going to have decreased, hypoalbuminemia. Anemia means in the blood. So you're going to have increased protein in the urine, but decreased decreased albumin in the blood. Guys, albumin is part of the blood, but what part of the blood is it? Protein, duh. So you have increased protein in the urine, decreased albumin in the blood. But remember, albumin is a type of protein. Professor D, why are you harping on this protein? Because you need to know it. But more important than that, what is an important function of the protein? It keeps the fluid and the blood in the vessels. So now we have all this protein that's spilling out in the urine. All the albumin that's supposed to be in the bloodstream is now in the urine. Guess what happens? All of the blood, all of the fluid that was supposed to stay within the vessel says, whoa, there's no protein around. There's no albumin around. It's party time. I don't have to stay in the vessels. I'm going to go out to the tissues. And that's why that patient is edematous. They're swollen all over the place. So when it comes to nephrotic syndrome, increased protein in the urine, decreased albumin in the blood, edema. I'm on number 3. What is the 4th thing you have to know about nephrotic syndrome? Patient's going to have high cholesterol, lots of fat in the bloodstream. Now, to be honest, I don't remember what causes the increased fat. I don't remember. Look it up. Somebody tell me. But you need to know that for testing purposes. And the 5th thing you need to know is that the patient will have frothy urine. Okay, those 5 things you see with nephrotic syndrome. Now let's talk about the corticosteroids, because this is what the question was based on, corticosteroids. Let me tell you something. If you don't know anything else, you better know these 4 things about corticosteroids. Any patient who's on corticosteroids, you're going to be concerned about these 4 things. Number 1, you guys know what it is? Hyperglycemia. Corticosteroids are very sugary. You better be checking that patient's blood sugar. Number 2, ulcers. They are very hard on the stomach. That's why you never give steroids on an empty stomach. Mess around, give the patient a bleeding ulcer. Number 3, osteoporosis. Thank you, Island. Osteoporosis. Corticosteroids make the bones very porous. The patient can bump into a table and mess around and break a bone. You got to be safety is a very big issue. And 4, infection. Corticosteroids decrease inflammation, right? They can mask the signs and symptoms of infection. That means by the time you start seeing these clinically relevant signs and symptoms of infection, that patient, they may be septic because corticosteroids mask the signs and symptoms of infection. So any slight elevation in temperature, any slight elevation in WBCs, you better be concerned about. Don't say I didn't warn you. All right, let's keep it moving. All right, what supports the diagnosis of acute glomerulonephritis in a child? Would it be frothy urine? Would it be polyuria? Would it be recent strep infection? Or would it be low blood pressure? Okay, looks like most of you guys are getting this right. Very good. A recent strep infection. And that's why it's so important. I say this all the time. You have to teach the parents to stop being so cheap. If their kid has a sore throat, they need to take their kid to the pediatrician's office to get a pharyngeal swab, right? We need to make sure that it's not strep throat, because a simple 99-cent antibiotic, that patient can get penicillin, amoxicillin, and we clear it out, right? But the parent decides to be cheap. They don't take that child to the pediatrician's office. That child doesn't get the antibiotics. And yeah, okay, it goes away, but 1 to 3 weeks later, boom, glomerulonephritis. Why? The immune complexes. Okay, so that's a very important teaching. Your child has a sore throat, take them to the pediatrician's office. Make sure that that child gets antibiotics if it is a strep infection. Okay. All right. Frothy urine we see in nephrotic syndrome. Polyuria, no. If this patient had glomerulonephritis, we'd see the opposite. We'd actually see oliguria. right? And that's not only for glomerulonephritis, that's across the board. If the kidneys are in trouble, you're going to see urine output go down. And low blood pressure, nope. Think about it. If the kidneys are in trouble, it could be glomerulonephritis, it could be nephrotic syndrome, it could be acute kidney failure. I don't care. If the kidneys are in trouble, urine output's going to go down. If urine output goes down, patient's holding on to fluid. If patient's holding on to fluid, what do you think is going to happen to the blood pressure? The blood pressure is going to go up, not down. Patient can have hypertension, not hypo. All right. What is the priority action for a patient sickle cell crisis? Are you going to administer fluids, apply heat, give high protein snacks, or do range of motion exercises? I know you all are going to get this right because I've been shoving this down your throat for years. Everyone's going to get this correct. I love it. You guys make me proud. Very good. IV fluids. You know what? I made a mistake. I didn't put oxygen as an option. I should have done that because as students, you guys see oxygen and you lose your minds. You see oxygen and you want to choose it every single time, even when it doesn't make any sense. Let me tell you something. Even if oxygen was there as an option, you're going to hydrate the patient first. The problem isn't lack of oxygen. They got oxygen. The oxygen's in the hemoglobin that's in the RBC, that's in the blood. The problem is it's not moving. So you're going to hydrate them so it can go to the tissues. It can go where it needs to go. Everyone that's sharing the live, thank you. All right, we're almost done. What should be emphasized about a tender, mobile breast lump? It's likely cancerous. It's likely related to menstrual cycle. It's likely a blocked milk duct, or it requires mastectomy. Thank you, Sar. Okay, guys, let's talk about this. This relates to menstrual cycle. Now, let's look at the question. What should be emphasized about a tender, not hard, mobile, not immobile? If it was, first of all, we don't diagnose, we stay in our lanes. We're nursing, right? But even for you to suspect something cancerous, it it would be it would be hard and it would be immobile. By the way, pain is the last symptom seen in cancer. So every other disorder that I can think of, patient's going to have pain. That's what brings them in to get checked, right? When it comes to cancer, by the time the patient has pain, it's already metastasized all over the body. So anyway, the correct answer is related to menstrual cycle. Why? Because when you get around the time of your menstrual cycle, your hormones are all over the place. And so there just may be fibrous tissue. It's not cancer. Look at the first one, likely cancerous. Stay in your lane. You do not diagnose. You are not a nurse practitioner. You're not a health care provider. You're not a doctor. Do not diagnose. You are not going to tell the patient that it's likely cancerous. Block milk duct, again. What diagnostic tests have you done? And even if you did, you're not going to be the one to diagnose the patient. And oh my gosh, requires mastectomy. So you're telling that patient that they need surgery. We got that from this. Oh, I'm so sorry. We're almost done. We're about to do our last question. I'm sorry. All right, guys, last question. What is a key teaching point for tamoxifen therapy? Are you going to teach a patient to avoid leafy greens? Are you going to teach them to report signs of blood clots? Are you going to teach them to take that medication with grapefruit juice? Or are you going to teach them to use NSAIDs for bone pain? I'm gonna fight you, Leslie. Try again. Good. Report signs of blood clots. So, this antineoplastic agent, guys, increases your risk for clots, for thromboembolism. So you're going to teach the patient if you experience leg swelling, leg pain, chest pain, you need to report it right away. We're going to be concerned about blood clots. Can you please post this on YouTube? I will. I will. After this video, I have to run, but I'll post it sometime this evening. Okay, guys, let's see how you did.